This portion of CardioSource Video News is supported by the makers of Xarelto.
Welcome to ACC.12. It's opening day. I'm glad you could join us. I'm Dr. Randy Martin for CardioSource Video News, and we're glad you're here. Let me introduce our great panel. To my immediate left is Dr. Peter Block. Peter is Professor of Medicine and the Director of the Structural Heart Program at Emory University Medical School in Atlanta. Next to Peter is Dr. Athena Pappas. Athena is an Associate Professor of Medicine at the Brown Medical School and also at the Rhode Island Hospital. And Dr. Chris Cannon, who many of you know. Chris is Professor of Medicine at the Harvard Medical School and Senior Investigator of the TIMI study group at the Brigham and Women's Hospital. So here we are again.
Here we are again.
It's fabulous, fabulous crowd. So there are late-breaking trials this morning. Chris, TIMI 50 came up. Tell us a little bit about it.
Well, this was a trial that Dave Morrow presented, obviously from our group, that looked at a new antiplatelet agent called Vorapaxar that blocks the thrombin receptor. So that's the most potent way to stimulate platelets, and thus, potentially a nice therapy. What was seen in 26,000 stable patients with atherosclerosis, 20,000 were post-MI, 5,000 with prior stroke, and remainder with PAD, that the overall benefit was seen with a p-value of 0.001, about a 12 to 13% reduction in cardiovascular death, MI, or stroke when adding the new PAR1 antagonist on top of aspirin and clopidogrel in the majority, but background therapy varied by the disease state. But there was also an increase in bleeding, about a 50% increase in bleeding. Absolute bleeding increase is modest. However, in the prior stroke patients, they had a substantial, about doubling in the risk of intracranial hemorrhage, and they were stopped early by the DSMB. So out of this, the big picture is that adding another antiplatelet agent, which was attempted in Charisma with clopidogrel, failed, did actually prevent more events. So as a concept, a very good one. The prior stroke patients we've seen again with clopidogrel, other combination pills, too much bleeding. So monotherapy really is all we have for stroke patients. And we're left with the patient selection of trying to find the patients who will benefit but then not have excess bleeding.
Right. Athena, what do you think?
It's similar to, we were just talking about some of the prior trials where they're adding a third agent, trying to really block the platelets. And the trade-off, there's no way around the trade-off of excess bleeding. But what we need, it seems, is tailored therapy. Who are those patients? We found out it's the stroke patients, but are there additional patients? Is there weight-based therapy?
Peter?
I'm having a deja vu all over again. In the early days of stenting, we used to give aspirin, and we used to give heparin beforehand, and then we used to give warfarin, and we used to give dextran, and used to get anything to stop thrombosis because we were worried about that. And patients bled all over the place. It was horrible. And so obviously now we're much better at that. The question that I have for Chris, and I think it really doesn't go so much to patient selection, is what about this new drug with just aspirin alone? Because the issue is that if somebody's given 3 medications after they leave the hospital, they're simply not going to take it. And it would seem to me if we could tailor the aspirin-clopidogrel combination to aspirin and something that may be a little bit better than clopidogrel, that would really be a good thing to know about.
Yeah.
And this study doesn't tell me that.
Well, very interesting, and that has been seen adding, obviously, warfarin on top of aspirin and clopidogrel. The 3 versus 2 is a bleeding. Here they found and analyzed it many ways that the benefit and relative bleeding was the same regardless of whether you were on aspirin alone, and there were some patients in the trial, or aspirin clopidogrel or the other combinations. Probably because it's a totally different mechanism. So aspirin, clopidogrel, or orthionipirines in general, and then this thrombin antagonist are very different modes.
So before we leave the TIMI, because I want to get to one other thing, so what's the take-home message for people that are tuning in and watching this, you think?
Well, I think there's a real risk reduction, and so for selected patients, you can significantly reduce hard endpoints, but you just have to carefully choose them to reduce the bleeding risk.
That's what you say?
I think that's fair. I mean, the fact is, if you give a lot of medication that make people bleed, and we have to be careful about that.
So we have another thing that piqued your interest a little bit. You want to tell me about it?
Well, I mean, is this the reset trial? Is that what we want to talk
I think
about?
let's go with
Yeah,
that.
the reset trial is an interesting trial having to do again with antiplatelet agents after stent implantation. This is a zotorolamist stent, and the question was, could they stop at 3 months rather than standard therapy going out to a year? And the short version is yes, you can. No difference in outcomes. I think that's an important step because nobody likes to take drugs longer than they need to. The problem with this study, and the investigators are very upfront about it, is that they stop the trial at 3 months and in 1 year, and they don't really know about the much longer term outcomes. And much of late stent thrombosis, of course, can occur after 1 year, even though the numbers are small. So yes, this is an interesting study. I think it tells us we can stop dual antiplatelet therapy after 3 months in some people in this stent population. But I don't think that we can sort of extrapolate and say everyone can stop after 3 months. I don't think that's fair to say.
Athena, what do you think?
I would agree, and I think, again, the issue is, we've seen this, are there patients that you can't stop at 3 months? Can we choose those patients? Can we find them up front? And does it apply then also to all the stents out there, or is it specific to this
Well, it may have to do with size of stent too. I mean, a great big stent has less chance of thrombosis
And do we know
than a
that?
small one. No, they did not.
Chris, final thoughts on this?
You know, here it's a moderate sized trial, so not definitive, but the theme that we've seen of the last 3 or 4 trials of not seeing a benefit of the extended therapy, I think is making us and myself in particular back away from the indefinite because there's ongoing bleeding risk, so that the 1 year is looking a little firmer.
Right.
And I've heard in Europe a lot of people are adopting a 6-month time frame, but certainly a year, but it used to go on for years.
Right.
And I think out of this contributes to evidence saying that maybe there is a more discrete time where that benefit risk is helpful.
Super. Okay. Well,
Great.
we're going to good information. We're going to take a very short break. We want you to come back because we've got some more exciting information from the late-breaking clinical trials.